recording. I caught you. You were very enthusiastic in describing what was going on in the 80s. And I looked it up. It said FDA approved PSA in 86 to
Yeah.
monitor patients already diagnosed. 94, they approved the PSA test as a diagnostic. So I want to take you back to the days of yesteryear.
Yeah.
What you were getting very excited. What was it like?
Well, okay. So first of all, yeah, the just to clarify some of the dates, the test became widely available in the late 80s. In Canada, it was 1989. I had been in practice about 3 years at that point, and the peak in incidence was 1993. So that's when the surge began. And I think one of the main triggers, partly it was just availability, but a New England Journal article first authored by Bill Catalona was published in 1991 on PSA as a screening test. So that was one of the major triggers for widespread acceptance of the test as a screening test. Based on what we know now, the test should never have been so widely adopted because the evidence for widespread adoption of a test as a screening test requires very, very high level evidence because you're not treating a disease. Particularly, you're basically screening for a condition that is so much more widespread than the proportion of patients who actually die from it. So, we know now much more about a lot of these issues of over-detection, over-diagnosis, over-treatment than we did then. But at the time, and I can remember Bill Catalona coming to a meeting in Canada where he argued for screening and very persuasively, despite the fact that a lot of these issues that we now know are so important were not really acknowledged or recognized. So, boom, all of a sudden, as I mentioned yesterday, all of the prevalent cases that were out there, the hundreds of thousands of men who harbored prostate cancer but were not diagnosed because there's no reason to suspect it prior to the PSA. They had the digital rectal exam was the test used for detection of localized prostate cancer, and we now know it's a very inaccurate test, really doesn't work very well, not sensitive, not specific. So all these men had prostate cancer. Suddenly the PSA came in and they were found to have an elevated PSA. They had a systematic biopsy, which had been described in the early 80s. And then they were diagnosed. And this really very unique, dramatic increase in incidence looks like a mountain peak where it increased dramatically in 1993 from about 1990 to 1993. And then the prevalent cases were diagnosed. So the annual rate of diagnosis, which is the incidence, started to go down. And it took another 4 or 5 years to kind of reach a normal level, which is the annual incidence that hasn't, age adjusted, hasn't changed all that much. The total number of cases has increased as the population has aged. Obviously, the older the population, the greater the risk of diagnosing prostate cancer.
So what was the incidence back then? And, like in 92 versus 93, you said there was a surge.
Yeah. Well, from about 1990 to 1993.
What
A
are the
steady
actual
rise.
numbers?
So now it's around 250,000 cases per year in the United States.
Mm-hmm.
And it reached, I think, about 2 or 3 times that. If the number is important, I can track that down, but somewhere around 5 to 600,000 cases.
So American men suddenly had an emergency they didn't know they had
Right.
just
And
because of a test.
correct. Basically. I mean, they were legitimately diagnosed with prostate cancer, but the other thing that happened around the same era was advances in treatment. So the nerve-sparing radical prostatectomy that was pioneered by Pat Walsh, who was at the time far and away the most well-known urologist and prostate cancer expert in the world. And the nerve-sparing operation he described in the early to mid 80s and promoted this, saying, you know, you do this operation, you have dramatically reduced risk of erectile dysfunction and incontinence. Prior to that, radical prostatectomy was a very feared and infrequently performed operation because the results were really pretty terrible, partly because it wasn't done very often. And when it was done, there was usually a lot of bleeding and incontinence, and erectile dysfunction was the rule. The nerve sparing was a genuine advance, but one of Dr. Walsh's firmly held beliefs at the time was that if you did this operation and the patient had a positive margin, meaning cancer at the edge of the specimen, implying some cancer cells left behind, you've wasted your time and you've harmed the patient. So who was the patients with the least risk of positive margins? Was patients with Gleason 6 prostate cancer. And at the time, it wasn't really, it was Gleason, the Gleason score went from 1 to 5. The Gleason sum, which is the most predominant, the second most predominant scores, was out of 10. 6 was considered to be kind of intermediate. Now, another 10 years later, 1 to 5 was abandoned. So 6 became the lowest. But then, you know, I can remember at that point thinking, well, Gleason 6 is kind of, that's intermediate. They're a 6 already.
What year are you talking about?
I'm talking about the late 80s, early 90s.
Mm-hmm.
So Pat argued that the ideal patient for radical prostatectomy was a Gleason 6. And because they had the lowest risk of positive margins. So there was,
would you say the word shit show is correct?
well,
It
I'll let
was
you
a
use
mess.
that. I'll let you use that word. I mean, listen, for guys like Dr. Walsh, who you know deserves enormous respect and made a huge contribution. This was not about protecting the business model or anything. They truly believed what they were saying, and that this was for the greater good of mankind, to eradicate the risk of death from prostate cancer by taking it out. So, and the irony, one of the other many ironies in this area is that there was in retrospect, a very advanced view about patients with incidental prostate cancer diagnosed at the time of TURP. So TURP, transurethral resection of the prostate, was in fact the commonest operation performed per organ in North America. I think actually probably in the Western world. I say per organ because there were more cataracts in those days than TURPs, but 4 times as many eyeballs as prostates in the population, because everyone has 2 eyes, and men and women both have 2. So a quarter as many prostates, but per organ, it was the commonest operation. And 10% of men having TURPs were found to have incidental prostate cancer when the resected tissue was examined by the pathologist. And there was a stage called T1A prostate cancer, which was only found at TURP. That was the definition. And it was low grade, and small volume. And what I was taught as a resident was when you have T1A prostate cancer, you don't mention the word cancer to the patient. You tell him that he had a few abnormal cells, he needed some monitoring, and you didn't treat it. And that was because it was known at the time that this was an incidental prostate cancer, that the men, it had been known for already for 30 years, since the 50s, that incidental prostate cancer in men who died of other causes was extremely common. 50, 60% of middle-aged and older men harbored the prostate cancer. You're finding it on the TERP, you don't treat it. So in retrospect, that was a very advanced way of thinking. And that's received kind of very little acknowledgement. And that was forgotten. So with the surge of PSA-related diagnoses and comments like Dr. Walsh's, there was this massive surge in enthusiasm for nerve-sparing radical prostatectomy. The ideal patient was thought to be low grade. And we have data from that era, from the 90s and the early 2000s, that approximately 95% of men with Gleason 6 prostate cancer were treated radically, either with surgery or radiation.
By the way, you said it doubled or tripled.
Yeah.
What proportion of those men were Gleason 6?
Yeah, probably about 35 to 40%.
And okay. And if you looked at those, you were saying 95% of them were treated with prostatectomy.
Or radiation.
I saw a chart from the Aqua program at the AUA, and it looks like there's been a switchover from prostatectomy to radiation. And the Gleason 6 people. Just
Yeah.
why is that?
So I would say a few things. There's many factors involved in that. Switchover, I think, is a bit strong. There's let's say there's somewhat of a shift. Say 10 years ago, if you look at the proportion getting surgery and radiation, it was about 60-40. And now maybe it's more like 40% surgery, 40% radiation, and maybe 20% getting one of the alternate therapies that didn't exist 10 years ago, like IRE, TULSA, cryo, etc. Didn't exist, say, 20 years ago. So there's many factors there. I think one is that the active surveillance concept, now I'm giving you my impression. I think there's been more pushback by radiation oncologists than by surgeons. The side of it, radiation is less invasive and has fewer short-term side effects. So in a way, the radiation oncologist can perhaps justify the over-treatment issue, which I'm sure they're aware of. So there's a lot of patients getting treated with grade group 1 prostate cancer with radiation compared to surgery. I think if you look at radical treatment for grade group 1, it's very predominant radiation over surgery now. Maybe it's that the strongest voices promoting active surveillance, mine and others, is coming from urologists, not radiation oncologists.
Mm-hmm.
Although this is a generalization. In my center, my active surveillance group is 2 radiation oncologists and myself, and they are completely supportive of this concept. So it's not a universal thing at all. Number 2, there's been this I would say, there's a trend of the large urology group practice associations starting up large clinics where they own the radiation machine. They hire a radiation oncologist, and they make more money referring a patient for radiation than they do actually operating on the patient. And there is data that this has resulted that this ownership issue does influence uh, treatment decisions and clinical practice patterns.
You know, back when there was that surge, what were people thinking? That we had an epidemic, or do they recognize that it was really this introduction of the test?
Well, I think for sure it was no, 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 the latter, the latter. It was crystal clear to knowledgeable people that this was due to case finding. Like imagine you're a clinician in practice and you're seeing all these patients with elevated PSAs. Well, what do? If a PSA is elevated, means they're at risk for prostate cancer, and you biopsy them and you find prostate cancer, and the pundits are saying you have to treat these patients, and so that's what was done. I mean, at the level of an individual practitioner, you're not seeing epidemiologic trends. You're seeing individual human beings coming in worried about their PSA, and you know, you want to diagnose them.
Well, so pretty quickly it was recognized that there was a problem with overdiagnosis and overtreatment. Or did people argue about that?
No, oh no, it wasn't recognized very quickly. It was not recognized at all. It took 20 years. So the surge came in the early 90s, lasted for 4 or 5 years, and still the increase in incidence related to PSA has continued, just not as dramatic as in those early years when all the prevalent cases were being diagnosed. It might be worth just explaining a little bit what that means. In other words, you imagine the test comes in and you apply it to a large group of men. Some men have normal PSA, some have the typical mild elevation that we see today. And of course, and then a lot of men have PSAs between 10 and 1,000. In other words, it's the first time they're getting the test. So today we don't see that very often because they're getting it sequentially. So you see the PSA rising gradually in patients who have prostate cancer. Whereas in those days, all of a sudden, boom, the test is done for the first time. You get this whole cohort of men who, if the test had been available earlier, would have been diagnosed 5 or 10 years earlier. You see what I mean? So that's why it was just such a dramatic rise. And then those cases are diagnosed, and then the incidence starts to go down. So just to kind of clarify that point.
Well, how prevalent was the use of the PSA test, and when did that peak?
I'm not sure it did peak. I think it definitely, look, there was not unanimity. It was a controversial issue. It's still a controversial issue, but at every single meeting, urology or prostate cancer meeting, would have a debate about screening, and there were very compelling voices on both sides. Part of the issue was there wasn't great data. The data evolved over time, and nowadays the most compelling data is from the European randomized study of screening, a massive screening trial involving more than 200,000 men. I mean, just an unbelievable initiative. And now we have long-term follow-up from that study. It was launched probably in the mid 90s or late or 2000 type of era. And so now we have data. We know that screening reduces mortality, but we didn't have that then. So the argument was, in the absence of data from a randomized screening trial, should you do it? And the believers said, well, we know early detection reduces mortality and treatment reduces mortality. I mean, for example, there were randomized trials, SPCG4, which compared surgery to no treatment, that showed a 50% mortality reduction. So the idea was, well, when you diagnose localized prostate cancer, you can reduce mortality by treating patients radically. By the way, the reduction of mortality was only in the higher grade cancer, not in low or intermediate risk cancer. So that insight came later. And the skeptics, who in retrospect probably had a somewhat of a stronger argument, said, no, you shouldn't screen until you have high quality data because the risks of harm of overdiagnosis and overtreatment are too great. So that argument still goes on, frankly. There's still not really a broad consensus, I would say, about whether, like mammography, there should be government-sponsored screening programs promoting every single male in the age group to be treated. There's really not, even now, it's like 40 years later or whatever, there's still not really a broad consensus about this.
What, what proportion of men actually had PSA tests?
Yeah, there is data on that. It varied by region, varied hugely by region. I think in it was roughly 50% in the United States. Canada, I think, was a little lower. There were regions where it was like 80 to 90% of men, and regions where it was 10 to 20%. And one of the pieces, there was data, for example, from Austria, where I think in the Tyrolean area, almost everyone was screened. And in other regions, no one was screened, and they showed a very significant reduction in mortality in the screened area compared to unscreened. There's a lot of confounders with that kind of data, but that was the kind of evidence that was used to justify, to justify widespread testing before we had the results from randomized trials.
Now, my understanding is that the PSA screening kind of took a fall at some point.
Well, so the problem was, okay, so now we're moving forward. So now you had this phenomenon where patients are being diagnosed with PSA, they're being treated radically in almost all cases. And it was obvious. So now we're talking about the kind of late 90s. So this thing's been going on for 8 or 9 years. It was obvious that for people with who kind of understood the issues, that there was a lot of overtreatment going on. Now, overtreatment is not in itself a terrible thing. So, for example, if you're trying to prevent a myocardial infarction and you put patients on aspirin and you demonstrate that, oh, there's a 5% reduction in reinfarction rates if they're on aspirin. So it means, the majority of patients aren't getting much benefit, but it's an aspirin. So it's like, who cares if you're over-treating with aspirin? But over-treating with a radical prostatectomy is a different story. So the thing about over-treatment is it's a kind of disease specific and treatment specific issue that's not the same for, it's not inherently wrong to overtreat. It's a question of the trade-offs of the risks and the benefits. So it became very clear, first of all, a lot of skeptics decide that the nerve-sparing operation wasn't quite what it was cracked up to be. Some patient-reported outcome studies started appearing that showed, incontinence was still 25% of patients, ED was 50, 60% of patients, whereas the Walsh data, it was like 90% potency preservation. Every urologist patterned themselves after Pat Walsh telling patients, oh, we do the nerve sparing, you have 90% preservation of erectile function, which simply wasn't true. So it was clear that there was a lot of treatment of indolent disease that carried with it significant side effects. And so that was the and papers started to appear, and you're familiar with these, like Jerry Chodak's paper on conservative management, Nicholas George's paper. These came out kind of early 90s, as I recall. And these, the implication of these papers is that a lot of patients had indolent disease, which was really known, and that you could manage them conservatively, at least in the intermediate term, safely. And but it was all or none. That was the issue. It was like radical treatment versus no treatment. So that's where kind of we came along, my group, and we decided, well, why don't we watch these guys and treat the ones who look like they're bad actors based on some criteria, rapid rise in PSA or grade progression on repeat biopsy. Seemed like just an obvious idea. So we got a grant to do that and started managing patients that way. And then that turned out to be quite an effective management strategy. But our first publication was in 2002. We had 250 patients, 5 years of follow-up roughly, and no deaths. And then there was massive pushback. And again, I think you know this story, but there was massive pushback for a variety of reasons. But I think certainly one of the reasons was the impact on practice patterns, saying you should stop treating these patients. But it was also genuine concern that conservative management would be a disservice to these patients, that they would be exposed to unnecessary prostate cancer death. And so for 10 years, there was this very, very heated debate, controversy, name calling. It got a bit ugly at times, but it was driven by strong conviction on both sides. And then, and I must say, I argued from the start that if all these patients were treated radically, the baby was going to get thrown out with the bathwater, and that screening would be discredited because of overtreatment. And that turned out to be 100% true. So along came the U.S. Preventive Service Task Force in 2012, who looked at it fairly dispassionately, I would say, looked at the overdiagnosed, overtreatment issue of low-grade cancer and said, this has got to stop. Screening there's too many adverse effects associated with early detection, level D recommendation for PSA testing. And that landed like a bomb. And that really vindicated the vocal minority of people who were arguing for active surveillance or more conservative management. And that ended the debate about overdiagnosis and overtreatment. It just ended it because it was clear that there was overdiagnosis and overtreatment, and that led to the recommendation to stop trying to do early detection at all.
And when was the 10-year period that you described, from when
2002 to 2012.
So was it your paper that triggered it then?
Ours was the first paper on that treatment management strategy of following patients and treating selectively based on these parameters that I mentioned. But there were other groups that really started doing it at almost the same time. And so papers started, the rate of publication of papers just on this approach just increased exponentially. But yes, ours was the first in 2002. I think the first Hopkins paper was about 2 years later. They were the other group, UCSF, Europe, the Prius collaboration. So by 2008 or so, or 2010, there were scores of publications with larger and larger cohorts, longer and longer follow-up, kind of supporting this strategy.
Now, did you have a follow-up in 2007 or when?
Yeah, well, we kept accruing patients, and re-examining them. I think we've done it. It's about 20 years. We've published about four or five times. So it was 250 patients in 2002. I think it was about 600 in 2007, and then we were up around 1,000 around 2012 or 13. And yeah, so in each time, almost we had a few deaths. We were inclusive. We included grade group 2 and 3. We had small numbers of grade group 3. They did very badly. More than half of them metastasized. It's not a good strategy. And then because we include grade group 2, we had about a 3% prostate cancer metastasis rate. Mostly grade group 2 at diagnosis. And the other limitation, so this was the pre imaging era. And based on what we now know, the failures were guys who had usually large anterior cancers that were just not diagnosed with the systematic biopsy approach without imaging, which tends to biopsy the posterior prostate because it's a transrectal needle. And so we just missed these guys who had these who had aggressive cancers in the anterior prostates, and they then went on to metastasize. So that changed dramatically with MRI, which we formally incorporated around 2013. It first became available around 2009, 2010.
Well, I want to interject something personal
Yeah.
here. 2010, in December 2010, I got diagnosed with Gleason 6, and my first doctor said, I have an opening in my operating room next Tuesday,
Right.
and I think that was probably pretty typical.
Right.
But I had done some homework and I found Egner, so I got a second opinion. And in that process, he showed me, it must have been, oh, well, he showed me one of your papers. I don't know if it
Okay.
was the first one. He said, well, the first doctor said, I can cure your cancer. So Egner said, yeah, he can probably cure it, but you don't really need the surgery.
Right.
Let me show you this study.
Uh-huh.
And so I read the study, and as I recall, my take home was it didn't matter if you were treated or if you were with radiation or surgery, or if you went on active surveillance, the outcome was the
Right.
same. That was kind of what I read.
For sure.
And I said, boy, why would you want to be treated? And
Yeah.
so I didn't. But
Yeah.
if I'd followed the first guy, I wouldn't have known.
Yeah.
You
That's
know,
that hasn't stopped, Howard. That still goes on. Not as commonly as it used to be. But yeah.
Egner said to me, he said, I'll go so far to say 10 years from now, your cancer will not have grown.
Uh-huh.
And in fact, I think it was better than that because, I had one biopsy that showed a millimeter of Gleason 6, one core.
Uh-huh. Right.
Every subsequent
Huh.
biopsy showed
Yeah.
nothing.
Uh-huh.
Yeah,
Right.
I've sort of de-intensified
Yeah.
for since 2016. All I've done is hit a phi test
Well,
every.
just on that note, one of the aspects of this whole story that has gotten very little attention is this phenomenon of spontaneous regression.
Right.
So most people think what a case like yours means is that you had very small volume of cancer to start with. They happened to hit it with the biopsy needle, and there just wasn't very much there. So your subsequent biopsies are negative. But there's a lot of evidence in the breast cancer field, particularly, that actually what happens is these small cancers, they're they don't just sit there kind of latent and stable. They actually regress and disappear in fact, in the majority of cases when they're a millimeter or so in diameter or less. And this has gotten almost no attention in the prostate cancer field, but I think it's actually a much more widespread phenomenon than we think, that the
I,
cancer
I
actually
can
just involutes and disappears.
I can introduce you to many guys who uh, have been on this for 15, 20 years,
Yeah,
and they have no sign
right.
of
Well,
any,
that still doesn't tell you whether it's just latent and stable or whether it has resolved, and that they've, with, because of their own innate immunity or the inherent senescence of these low-grade cancer cells, that it actually just disappears. The fact that they're stable doesn't help you sort that out. It really is something that has to be, uh, you'd have to do some studies specifically to try and make that distinction, like rebiopsying exactly the same site serially over many years type of thing. Those kinds of studies largely have not been done.
that's different than MRI invisible.
Yeah, well, presumably these are invisible, but yes, it's related in the sense that the invisible cancers are biologically and genetically different from the higher grade cancer, the visible cancers. Yeah,
So yeah, I mean now Egner and then my current doctor, Dr. Helfand,
yeah,
say uh, it's still in there lurking somewhere. And
right. So that's the conventional wisdom.
yeah, so all right. So then okay, we have the MRIs. Now I had my first MRI just months after the biopsy,
Right,
and I got a confusing result. There was something that coincided with the thing found in the biopsy, but then there was another lesion supposedly on the other side.
right.
And behind the scenes, I was consulting with Jerry Chodak, but we were cordial, and
Yeah,
he said, you know, you could choose to believe that's a lesion. I think that it's an artifact. And I had a horrible experience getting this MRI. The previous patient died in the suite, and they forgot to order my probe, and
I
uh,
see.
and I got claustrophobic,
Yeah,
and the
that happens.
technician was like Torquemada, the Grand. I ended
All
up
right.
with tinnitus because the protection fell out, and they said that would get better. It never did.
Uh-huh.
So but 5 years later, when I switched doctors, I had another MRI. I was able to go into the machine feet first, and I could tolerate it better. And they didn't find anything.
Right.
So, you know, but I
Yeah.
was establishing with a new doctor, and so he did both a systematic biopsy and an MRI.
Hmm.
Uh, and they didn't find anything. And pretty much
Right.
since, I haven't had anything since other
Right.
than, a PSA in effect. But I'm wondering, okay, back in those days, I think Egner at the time told me 6 to 10% in 2010 went on surveillance. Is that about right?
Uh, that's certainly in that era. I mean, I'm just trying to think when the data from this comes from the Capture registry, and I thought it was a little earlier than that, but that's in the ballpark. Yeah.
So that was my situation.
Yeah.
But plus the MRI was screwed up as far as I was concerned.
Right. Right.
But I survived. But okay, in those days we had we had a biopsy and then we had an MRI. And my understanding is this was a catch-22 from insurance. Insurance wouldn't, at least in the US, cover this unless you had proven cancer.
Right.
So did
So
it,
that was a huge issue. of MRI availability, particularly, funded by insurers, was very limited in those days. Patients, I'm more familiar with the Canadian situation, but basically patients either had to go to the States to a private clinic or very quietly, because it was not really approved. MR clinics would start to offer MRs to patients in Canada for pay. But it's interesting, it was only for patients who, let me just think, once they were diagnosed, then it was an insured service, which meant it couldn't be offered privately. So there was this it was really a screwed up situation. The guys who really needed it couldn't get it. And the guys who the data wasn't really there yet back then to justify it. I mean, a lot of people thought it would make a big difference, as it turned out to do, but the ones who wanted an MRI who hadn't yet been diagnosed had to pay for it.
So did it make sense to do, is it ass backward?
Well, it made sense to do it. So now we have randomized trials showing that there's but 5 of them. I led one of them. Randomized trials showing that MRI before biopsy results in more diagnosis of significant cancer, less insignificant cancer, and 40% of men can avoid a biopsy entirely. So it's very, very much worthwhile to do imaging before biopsy. But back then, all we knew was, MRI often found the cancer. So it's in a way analogous to the whole PSA story, that you have not high quality data, but the data that is there looks very, looks good, but it's not high quality. It's not from randomized trials. It's basically case finding. So this is kind of one of the oldest controversies, comes up over and over again in medicine. How high quality data, how high does the quality of data have to be to justify an intervention like screening or treatment? And, the problem is the high quality data is often not there. So then that leads to kind of a debate and a controversy.
So, all right, you mentioned the Preventive Services
Yeah, task
Task
force.
Force. Mainly what I've heard about it is a lot of bitching on the part of some patient advocates who were advocating back then, uh, and also from urologists
Hmm.
who, felt like a great injustice had been done. And now the seeds were sown, and now we're paying the price because suddenly there's a tsunami of advanced cases that are popping up.
But, look, so first of all, so much of this depends on what lens or what frame of reference you're looking at it from. If you're looking at it from the frame of reference of a patient advocate who really is interested in reducing death from prostate cancer, and you look at it from the perspective of a practitioner who wants to find patients with prostate cancer at a point where they are still curable, PSA looks great. But if you look at it from a broader perspective of the total impact on the population, including all the overdiagnosis and overtreatment, it's much more in the gray zone. And to their credit, the task force in 2012, as you just mentioned, conservative management was 10% or less. Well, say 2010. Which is actually when the task force was doing its deliberations, because it takes a while to get through something like this. So I think in retrospect, it's completely understandable that they came up with that recommendation. And to their credit, they changed it about 3 or 4 years later.
I think it was 2018.
I thought it was 2016, but it doesn't matter.
Yeah.
But they changed it mainly because of the adoption of active surveillance. So all of a sudden, the overtreatment issue is much less compelling, and you weigh that's the downside. And also, there's increasing data from European screening study and so on the benefits. And so they came out with a neutral recommendation, which basically said patients should be informed and make their own decision, which is which is a very acceptable position, I think. And so they changed. Canada still has the 2014 negative recommendation, which essentially parroted the US one. It's nothing to be proud of. One of the issues with both these panels is they largely rely on they're non-expert panels by design. So this is 100% the case in Canada. We're trying to change this. It's largely true of the US Preventive Service Task Force. They had one or two guys who were knowledgeable about prostate cancer, but mostly sometimes they're not even physicians. They're people in various aspects of the health sciences with no expertise in the uh, in the field. And the idea being that if you are an expert in the field, you have a dog in the fight, you can't be trusted to provide an unbiased view. But what that also means is you think about an area like prostate cancer screening, it's extremely complex. It's not just the data that's relevant is not just the results of randomized trials, of which there's really only two, one positive and one negative due to contamination, the PLCO. But there's more than 1,000. There's thousands of other relevant pieces of data related to imaging, biomarkers, tumor heterogeneity, uh, many aspects to this. And a non-expert panel can't possibly incorporate all of those thousands of pieces of evidence. They are stuck with looking at just the randomized trials. And because there's no experts pushing back, they tend to come up with, and this is often the case, a more negative view of these early detection strategies, whether it's mammography, colonoscopy, PSA, you name it, the same trend tends to occur. So that's been very much an issue in Canada. I think it was also an issue with the US Preventive Service Task Force. But again, they probably in part because of the pushback, they moved to a neutral recommendation a few years later, and that's where it lies. But
Well, actually, they're gearing up now for a
yeah,
new review.
yeah.
So, do you have any crystal ball on what they
Well, I would
likely will
say
do?
the field has advanced dramatically. And with the current strategy of imaging before biopsy, of not biopsying men who have negative imaging, of not testing men who are too old or too young, of reducing the frequency of testing in low-risk patients, et cetera, et cetera. At least in the prostate cancer field, I think it's not a controversy anymore that there's a widespread acceptance that this has value if it's done right. So whether the task force will agree with that, I hope so. I think they probably will, but you never know.
Okay, when did sort of the pre-biopsy MRI idea come in?
Um, I would say about the idea came in, shortly after the MRI data started being promulgated that the MRI is very good for detection of prostate cancer, for identifying the presence of prostate cancer. And a group of us, it took randomized trials to really prove that it was superior. And those got launched, I would say, in the teens, 2015, 2016, 17 sort of thing. A number of them partly led by the UK group at, University College London, partly led by me in Canada. Other people around the world launched these randomized trials. The first one was the Precision trial was published, I think, around 2020, and it was strongly positive, and that basically changed practice. That plus the other trials.
So it's something that I've been hearing patients talk about anyway is, I mean, there's all of these biomarker tests.
Yeah,
And the way I see it, it looks like 40 to 60% of biopsies can be avoided if you go with one of these tests, I think.
biomarker test.
Yeah,
Yeah,
but maybe typically 50% can avoid
right.
it. And so actually, it's a physician I know who is also a patient. He's
Okay.
I think he's a gynecologist actually. He keeps mentioning to me the idea of combining uh, a pre-biopsy MRI and one of these biomarker tests.
Yeah.
So, is that a strategy? I
Yeah.
mean,
So the interesting thing is there are these two parallel streams of investigation. The imaging stream, which is MRI, now microultrasound, PSMA, which is very it's very phenomenological. Like you have an image, you analyze the image, tells you location, size, to some degree grade. And you have the biomarker world, which is essentially molecular genetic strategy. So looking for alterations in mainly gene expression to try to identify higher grade cancer. So from a scientific view, they are like polar opposites. One is molecular biology, one is pure, is there an image? And yet they're both trying to do the same thing, which is to find the patient who's got aggressive prostate cancer. And they both work. So to some degree, and the question you're asking is essentially a sequencing question. Like, the patient got an elevated, so let me just say, first of all, PSA is not going away with these other tests, I don't think. And the reason is the negative predictive value is so powerful. It's not so much the ability of PSA to identify patients with cancer. It does that, but not very accurately. It's the very, very powerful ability of PSA to say when it's low, this patient is not at risk at all. That's massive.
mhm.
So that's why PSA is not going away, because when it's low, end of story. Less than one in a 60-year-old, for example. So then the question is, if the PSA is the initial test, if it's elevated, what do you do next? And you can do biomarker. If it's negative, in theory, you stop. You can do imaging. Also, if it's negative, that's my and many people's approaches, you stop. Which should you do first? Ultimately, it comes down to things like cost and availability. So the molecular tests are not cheap. They cost about the same ballpark as an MRI, roughly. It's about like $600 to $1,000.
Mhm.
Um, Availability is an issue. So MRI may not be available. Quality of the MRI is an issue. On the other hand, the MRI gives you a ton of information, whereas the biomarker just gives you a risk score, say low, intermediate, high risk. The MRI tells you about location, tells you about size, density. So because of that, my sense is the imaging first strategy is winning compared to the biomarker strategy. Um, The
Is there a
biomarkers,
synergy in combining them?
well, sure there is. I mean, there's a synergy in combining them, but now you're doubling the cost. So I can tell you in my world, I don't use, let me just, so first of all, free versus total PSA ratio is very powerful. And you don't hear much about it. I think maybe it's too cheap, it's not sexy enough. But so free versus total ratio and also PSA density, which is, ratio of PSA to prostate volume. These are both very strong predictors for the presence of significant cancer. Um, so I use those, but in my world, and maybe it's a little different in Canada, where we have to send the biomaterial across the border. There's a cost to the patient and so on. We don't use those those molecular biomarkers besides PSA, free versus total PSA, much at all. But imaging has now become very widespread prior to biopsy. I would say it's the standard of care. I think it's different in the States. It's partly related to insurance coverage. If there's coverage of the biomarker, patient doesn't have to pay, why not? But it really comes down more to, I think, the financial issues than actually the performance.
Well, okay. I'm looking at my notes here. Now, I was talking to Carolyn Moore at some point.
Yeah,
Actually, I was on a panel that she ran, and
yeah,
I'm in sort of this goofy position of being a patient, but also being a journalist who,
right.
and there's some conflict of interest in that, but I suppose.
Okay.
But at any rate, I was part of the committee that she ran. It was for Movember,
Yeah,
and I was talking to her, and she was saying how because of the MR, pre-biopsy MRI, they've had a decline in England of active surveillance patients.
for sure.
And I think she said maybe 6% of these low risk patients end up on active surveillance. I think she said it, and it's like 30% in the US.
Well, I think it's more accurate to say not so much a decline in active surveillance, a decline in the diagnosis of low risk prostate cancer.
Okay,
So that's what came first. Like if you do only targeted biopsies, you still find grade group 1 prostate cancer, but about half as many. That was our data, the randomized trial we did, which was called the PRECISE trial. It was almost exactly the same in the UK trial. So the diagnosis of low-grade cancer drops by a half, which is good.
right. Well,
Uh,
you're saving men from biopsy, you're saving men from being diagnosed.
that's it. That's exactly right. So the question, I think that's why, that I believe her point was that active surveillance is less common because there's fewer eligible patients. That's different from saying in the eligible patients, they're less likely to get active surveillance. I'd be very surprised to hear that.
Yeah, I just found my note from her. I think this is right. She said only 6% of low risk men in Britain are diagnosed, compared with like 30% in the US. Although I'd
I
heard
mean,
that,
only 6% of men who are diagnosed with prostate cancer have low risk. Is that what?
yeah,
Yeah. I'm surprised it's that low. It was 20% in our study, but it's certainly reduced from 40. It used to be 40 with systematic biopsies, 40%. Now it's around 20 in our data, and maybe it's as low as 10 in some sort. It depends a bit how aggressively you biopsy.
I think she said it was like 30% in the US, but think
Yeah.
I think somebody else, another researcher in the US said it was like in the 20s.
Well, listen, it's evolving because lots of people are still doing systematic biopsies. So how much grade group 1 prostate cancer you find is very much a function of whether you're doing multiple systematic biopsies in addition to the targeted.
Well, no, it's funny. I've heard he's an active surveillance guy, another physician. He's one of the medical directors of I think Blue Cross Blue Shield of California,
Uh-huh.
and he told me that if a doctor wants to make money in the U.S.,
Yeah.
he should do biopsies. Biopsies have the biggest payoff on the time.
All
Uh,
right.
you know,
Yeah.
he's not in favor of that, but that's the
Well,
way.
but that so I know there was some economic analyses that said, active surveillance is more expensive. They were based, in my opinion, on faulty assumptions, which is that the patients needed to have very frequent biopsies. Largely, imaging has replaced the very frequent biopsies. So we now essentially no longer biopsy patients where there's not a target, even on active surveillance. And we only rebiopsy them if their imaging has changed or their PSA is starting to look ominous. So we do a fraction of the biopsies that we used to do. So if you're going to argue that you're going to make a better living doing biopsies on active surveillance, at least the way it's now largely done, you would need a very large cohort of thousands of patients to do that.
Now, the feeling I get as a patient and having lived through a lot of this
Yeah,
is that, the pendulum is swinging and it swings one way, it swings
yeah,
back, and then it swings
for sure.
again. I mean, you agree with that perspective.
Well, the pendulum has swung towards active surveillance dramatically. Not 100%, we know there are still lots of clinicians in the States who don't offer active surveillance to their low-risk patients. There's still a view out there which is wrong, in my opinion, that if the amount of grade group 1 increases, the patient should be treated radically. That to me is incorrect, but I have partners who practice that way. But nonetheless, compared to 15 years ago, there's been a dramatic change. I think the pendulum now is swinging towards focal therapy, and there's somewhat of a gray zone where patients were, for example, with very high volume grade group 1, particularly if they're young patients, particularly if they have uh, positive imaging, say PIRADS-5. We know from the radiogenomic data that PIRADS-5 cancers tend to have worse genomics. We don't know yet if that also applies for grade group 1, but it certainly may. So those patients might be candidates for focal therapy in many people's minds. And then the other group is the grade group 2 with small amount of pattern 4. So they do well with surveillance, although not perfect. They have like about a 10% 10-year metastasis rate with active surveillance. It's higher, but 90% are okay. So they're in the gray zone for focal versus active surveillance. And I sense there's a bit of a swing of the pendulum back towards focal type therapy for these patients in the gray zone. Uh, but it's certainly, it's the swing of the pendulum pales compared to what we went through from radical treatment to active surveillance for low risk patients.
I gotcha. I'll tell you, I really appreciate your taking the time.
All
And
right.
is there anything else I should have asked you, or have we beaten this horse?
Oh no, we're just getting started, Howard. I
Oh,
think no, I mean the other message to me is about the whole active surveillance thing is acknowledging the importance of addressing other health issues with these patients. So, for example, there's just a paper published on uh, a topic that I felt strongly about for a long time, which is advising patients with newly diagnosed cancer to stop smoking. And the data is really compelling that that is when the patients are really receptive. So you can get these guys, you spend as a clinician 2 minutes with a newly diagnosed grade group 1 prostate cancer patient, telling him to stop smoking. You have done more for that guy than anything you are going to do for his prostate cancer.
Mm.
So, if he's a smoker. So and now we have data about this. So smoking, dietary modification, exercise, particularly avoiding obesity and so on. These are really the major health issues that you can favorably influence the patient if you have that discussion with them and they are primed when they're newly diagnosed.
Was that study you mentioned specific to
No,
prostate cancer?
no, it wasn't. It was all cancers. But they actually showed that there was a mortality benefit, the survival benefit, where the doctor spoke to the patient about smoking cessation. It made a difference in terms of survival. Like it's pretty remarkable.
Well, I may hit you up for a link.
Yeah,
I'd like to
yeah.
take a
I
look.
put a slide together when I saw that paper. I'll send it to you.
It's interesting. Well, I mean, the big message that I have in talking to these guys is with low risk is worry about your heart a little bit more,
Yeah.
heart healthy.
Well, yeah. Heart healthy is prostate healthy.
Yeah.
That's Mark Moyad's formulation, and it's definitely true.
Although, 20, this upcoming year, I'll be 20 years since I had a STEMI.
Uh-huh.
So, I mean, I was in peak condition and I got a STEMI and I only walked away from it, I guess, because I had been doing such a good job with exercise and diet. I had all this
Interesting.
collateral blood flow.
Yeah,
But yeah, my anniversary is coming up, 20 years.
really.
Yeah, yeah, I'm not
Well,
supposed
you've dodged a few bullets, Howard.
to, yeah. Fortunately, the real kind too. But I've never smoked. I never drank. Have exercised.
Right.
So, well, and it's funny. I wrote about the first personal health story I ever wrote about was about my heart attack.
Huh.
One of the columnists at the Chicago Sun-Times where I worked said, "So was it worth it? All the stuff all the
Right.
stuff you did, and you ended up with a
Right.
deadly heart attack."
Yeah.
I
Yeah.
think he kind of missed the point because all the
Right.
stuff made the difference. So,
Right. Right.
at any rate, I have to do something, and maybe I can run my draft.
Sure. For sure.
Okay,
I
just
just sent you the slide, the smoking
okay.
slide. All
Better the
right.
smoking slide than the smoking gun.
Yeah.
Or maybe that is the smoking gun. But anyway, thank you for the
All
tip.
right. Happy Hanukkah, Howard.
Yeah. Hey, we got a new menorah.
Oh,
A neighbor asked if we had an extra menorah. Well, we
uh-huh.
haven't used our menorah. First, our dog kept warning us about the danger of fire.
Uh-huh. Right.
He died, unfortunately. Then the cat, she burned her whiskers getting too close to
I
the
see.
stuff.
I
So
see.
we just bought a new one with LED lights. So
Uh-huh. Uh-huh. Right. I
we're
see.
we're
I
back
Howard.
in we're back
Shocking.
in the
Very shocking, Howard.
well, if they had LED lights back in the time of
Right.
Maccabees,
Right.
it would have been a different story.
Different story. Yeah.
But
All right.
anyway, take care. Bye
Okay.
now.
Be in touch. Good.
Okay,
Bye-bye.
bye now.